About the same.
Okay, good morning.
Good morning.
So this presentation is kind of in response to a lot of questions I've gotten from people in the various departments here, kind of wondering exactly what I do. And so, you know, we all share a lot of the same patients, so I think it's good to have good communication and just understand. You know, I followed a couple of the pain management physicians around the other day to try to get a better idea of what they do, and so let's just jump right in here. All right, so the word chiropractic literally means to do by hand. It comes from two Greek words, care meaning hand and practikos meaning practice or to do, to act. So chiropractors have been manipulating the spine since 1895 when D.D. Palmer pressed on a young man's back and had a miraculous recovery. But with modern chiropractic, you know, chiropractors do a lot more than just spinal manipulation. So you know, we do soft tissue treatments, we do therapeutic exercise, counsel our patients with you know, ergonomics and modifying daily activities, nutritional counseling, meditation, dry needling, taping, traction, many modalities, and let's see. So spinal manipulation is, you know, still the most used tool by the chiropractor, and as a treatment form, it's been around for thousands of years. Hippocrates was considered, you know, the father of medicine. Was known to use it. It was used in ancient China, and even was depicted in cave drawings as far back as 14,000 BC. So a lot of people are apprehensive about, you know, trying spinal manipulation because, you know, it can be a little upsetting being, you know, turned and twisted and popped. So while no intervention is without risk, spinal manipulation is among the safest options for the treatment of spinal pain. The most common adverse effect is muscle soreness, and this usually disappears after a day or two. Now, usually, you know, I find the research finds, and I find that, you know, about half the people that I treat do have some muscle soreness after the first treatment or after the first one or two treatments. That usually just goes away. Their body kind of adjusts and gets used to the motions that they're going through. And then the most severe and life-threatening is vertebral artery dissection with cervical manipulations. Now this is extremely rare, as I'll point out here. This was a study done in Canada where they surveyed 4,500 chiropractors and, you know, asked if they had ever been made aware of a patient having a vertebral artery dissection after manipulation, and they calculated that the likelihood of a chiropractor being made aware of it was 1 in 8.06 million office visits, or 1 in 5.85 million cervical manipulations, or 1 in 1,430 practice years. So you have to be a chiropractor doing a lot of cervical manipulations, practicing for over 1,000 years, almost 1,500 years, for this to become a serious risk. And here's another study for the safety treatment of disc herniations. And so it's been proposed that, you know, cauda-equina syndrome might occur with manipulation of disc herniations, and the calculated risk is about 1 in 3.7 million, which is, you know, much. I mean, it's like winning the lottery, getting struck by lightning. That's the kind of risk we're taking here. So the risks associated with spinal manipulation. This is from the journal the American Journal of Medicine in 2002. And they had a bit higher estimation for serious complications. So I mean, this is including the arterial dissection, disc herniation, and caudate equina syndrome all lumped together. So the incidence of serious complications is about 1 per 2 million manipulations to 1 per 400,000. All right, so how does it work? The answer is nobody really exactly knows for sure, because the mechanisms are extremely hard to actually test, because we're talking about, you know, these biochemical changes and neurological changes. But you know, it definitely has something to do with improving motion in the joints. Your body has, you know, natural pain-killing mechanisms where when you activate mechanoreceptors in the joints, it causes changes in the spinal cord that can mask, cover up the pain as it reaches the brain, or the brain stem. So here in this diagram, it shows pain, muscle spasm going into the dorsal horn here, and then you have things like manual techniques, trigger point therapy, rehabilitation exercises, chiropractic adjustments, things like nutrition. They all have inhibitory effects on pain, while, you know, damage to the joints or you know, trigger points, things like that, have the stimulatory effects to the pain nerves. And you know, there's no single cause of pain, so you know, results with any kind of treatment for pain are hit or miss. And these are some possible explanations for, especially for how people get very fast relief. Every now and then, you know, you'll do a manipulation and they get instant relief, and it kind of just depends on what the cause is. And usually you don't really know exactly what's going on. So there can be fixation of a joint caused by adhesion, fixation from nuclear fragments, where, you know, just opening up the joint, a meniscoid or some kind of fragment within the joint can be freed and moved out of the joint. You know, disc deformity, mechanical joint locking, motion segment buckling, compression or traction. So I mean, if the joints are just too compressed, then you can imagine how opening it up, distracting the joint would provide relief. And then you have somatosomatic reflexes. So that we'll get into that in just a second. So in 1965, Melzack and Wall published their famous gait control theory of pain. And so this is basically what I was just talking about. So the stimulation of mechanoreceptors are blocking the stimulated pain nerves. So the gait idea was that, you know, you open the gate to one type of stimulation, like mechanoreception, you know, just the motion sensation, and then it closes the gate for the pain. So it's kind of just the idea that your central nervous system can only process one type of input at a time. So one analogy is, you know, you bump your head, it hurts, and then your instinct is to rub it, and that rubbing, it makes it feel better because you're stimulating those mechanoreceptors, and it's kind of barraging your brain with stimulation that kind of takes your mind off of it. So somatosomatic reflexes, this gets a little complicated, but so Weick and Gillette proposed that manipulation stretches the mechanoreceptors in the joint capsule, and this results in an inhibitory effect of pain via the interneurons in the substantia gelatinosa of the cord. So, you know, it's the region of the spinal cord where there are all these interneurons. Those are neurons that communicate to the other neurons. So they have all these branches, all these dendrites that are just sending out these inhibitory signals. If they are so if you stimulate this neuron, it sends out this inhibitory signal to the others. And then reflex muscle spasm is another example of somatosomatic reflex. A positive feedback loop is mediated by the gamma motor neurons. The gamma motor neurons are the ones that control the length of the muscle, the tension. And so a facilitated segment is the idea that a piece of the spinal cord, just an area of the spinal cord, becomes facilitated, becomes easier to activate, especially during chronic pain. And when you have an area of fixation in the spine, the joints, that area of the cord becomes facilitated. So the thresholds where the nerves fire, those pain nerves, lowers, so it takes much less stimulus to activate those pain nerves. So that's how you end up with the chronic patients that you just barely lightly touch their back and they just writhe in pain because those pain nerves are so activated and their threshold is lowered. And this, Irvin Core talks a lot about how manipulation or stretching and manual techniques can reduce muscle tension and muscle spasm. And he proposed that a high velocity, low amplitude thrust, which is the main type of thrust that chiropractors use, would produce a barrage of afferent pulses. So impulses going from the joints to the spinal cord and the brainstem. The muscles would respond by reducing gamma gain, meaning those gamma motor neurons would kind of ramp down their signal saying stay tense muscle, so it would just make the muscles relax basically. And then another theory was a more mechanical actin-myosin bridge. So with the muscles you have the actin and the myosin, and when a muscle contracts they shorten, and so this was a much simpler idea really, that you could end up with some permanent bridges there where just the actin and the myosin don't release, and then a manipulation could produce a fast stretch to actually break those bonds mechanically. All right, so in simpler terms, Aboriginal cultures, primitive cultures do not really have any back pain. You only find any significant amount of back pain in the more developed cultures. And so in theory, this is due to the fact that these people are using their musculoskeletal system exactly how it was designed. They're hunting, they're gathering, they're picking berries, they're just being active all throughout the day, engaging their core. They're providing all that proper joint motion, just in the way that the spine was meant to be used. And so even the most active athletic American is a couch potato compared to these people. So here's how I basically explain things to a patient. I say, exercise and motion are like a vitamin for the musculoskeletal system. Vitamin is something that your body needs to be able to function properly, and manipulation is like a megadose of motion. So you're providing a lot of motion to just one problem area. So this is why it can provide relief for so many different musculoskeletal pain conditions, regardless of the exact cause. And it should be used in combination with a more active lifestyle and exercise, so that I look at it as a push to get back out there and to get more active. It's not usually a long-term fix by itself. So if it can provide enough pain relief that they can actually go out and start walking, start biking, start jogging, whatever they can do at home, then that's really where their long-term benefit comes from. So, working together, as time has passed, chiropractors have become more accepted and integrated into medical facilities. But positions like mine are still rare. Most chiropractors are practicing out on their own. You see one on every street corner. You don't have that many in hospital settings or multidisciplinary settings like the one I have here. So I think that's largely due to there's conflict of ideas, and there's also a lack of communication and understanding between the health professions, or among the health professions. And research supports the efficacy of chiropractic techniques for reducing spinal pain. But I think more research is needed to support co-management and collaboration between chiropractors and other health fields concerned with musculoskeletal pain. Now, I looked around for research on that. There are several studies out there with chiropractors in hospital settings, but it's more of a comparison between chiropractic and pain management, or chiropractic and physical therapy, or chiropractic and you name it. There aren't really any studies that I could find that really ask the question, well, what if we combine chiropractic care with all these other disciplines? Can we get a synergistic effect? So, I mean, this is what I found. This was from it was a British study that was conducted at a National Health Service hospital. And so they randomized groups of back pain patients, and half of them went into the chiropractic clinic and half went to the pain management clinic. And the chiropractic clinic did 5.5 points better on the Rowan-Morris disability score. Chiropractic treatment was more effective than hospital outpatient management, mainly for patients with chronic or severe back pain. A benefit of about 7% on Oswestry scale was seen at the 2-year follow-up. And so this is from the British Medical Journal. For patients with low back pain and whom manipulation is not contraindicated, so no red flags, no cord injuries or things that would be a contraindication for an adjustment. It almost certainly confers worthwhile long-term benefit in comparison with hospital outpatient management. But again, this is comparing. It's not really looking at what can we do together. What kind of benefits would we see if we combined all these strategies? And this one actually looked at a specific protocol for radiculopathy, and 85.5% of radicular complaints. I wasn't a big fan of this study because they didn't do a long-term follow-up. I mean, it can be somewhat easy to produce a short-term effect, but a lot of radiculopathy patients, they'll try something and say, oh, I feel great, and then a month later they're just back to how they were. So, all right, so this is Dr. Elder here. He really wanted to see this, but I guess he's too busy. But so these are the techniques that I use. I put in a few videos here to be able to show you exactly the types of manipulations and techniques that I use. So diversified technique is the most commonly worldwide used chiropractic technique. And if you've ever seen an adjustment, it was probably a diversified or something like it. It's a high velocity, low amplitude thrust. So you're bringing the joint to what's called lockout, where you just feel the end range, you feel resistance in the tissues, and then you provide just a very quick but gentle thrust to bring it just past that end range. All right, so here is a lumbar side posture manipulation. I think I'm connected. Oh, I have to be connected. So it usually feels good for patients. I mean, a lot of the really sensitive chronic patients, it doesn't feel so good at first.
The spinal process of T5 in my web space. So we're going to block the segment below, and we're to get extension. You would extend the T4 over the T5 just like that. Okay. If we're looking for more of the flexion component, you would take your into flexion of that segment and flex T4 over T5 and get a little bit of a thrust.
Yeah, I think that last one was actually a PT doing that. I don't think it was a chiropractor, but that's pretty much the same technique I use for most my thoracic spine pain patients. All right, so Flexion Distraction is, it doesn't use any high velocity thrusts. It's very gentle, rhythmic motion. It's using a special table where, there are cervical ones, but the one that I use, I'll mainly use it for lumbar. But the bottom end of the table where the legs go will move up and down. It'll move side to side, and it'll also rotate. So you can just provide that full range of motion for patients in an offloaded setting where they're not, they don't have the forces of gravity pushing down on their spine. And it's been proven with research to be effective for disc conditions, post-laminectomy syndrome, and spinal stenosis. So this is a technique I use more for the very sensitive patients, more chronic patients, and more elderly who can't really tolerate a diversified manipulation. Like I said, it's a lot gentler, it's slower. It's not as much of a kind of shock to the system as a more traditional chiropractic adjustment.
So in the meantime, you say this technique is less traumatic than the high velocity, obviously.
Mm-hmm.
So would this be something that we could utilize like in between, like post-surgical, like immediately post-surgical?
Well, I don't know if there have been any safety studies on immediately post-surgical. So yeah, I typically will wait about 3 months, 90 days post-surgical.
But that's the time frame that we're looking at.
Yeah.
But that would be the time frame for the high velocity also.
Well, for high velocity, I usually wait about 6 months post-surgical.
Okay.
I mean, it just depends. If it's a fusion, I don't do any high velocity.
For 18 months. Or ever.
Not in that region. Not in that region anyway. I mean, of course, when you do have a fusion, the segments above and below tend to become degenerated. They might need some more high velocity. But I mean, of course, if you have rods in your spine or you have the cage, and it's not. It just it doesn't really make sense to be trying to push
think you should do a study to see how chiropractic integrates with everything else here.
Right.
If you're saying there's no like literature out there, it doesn't make sense to see what an integrated practice looks like.
Right.
It's very hard to tease out chiropractic's contribution to the because you're going to get patients that are going to be tapped by their nature. Nothing else is working and that sort of thing.
Right.
I don't know how to design it, but like it'd be interesting to look at patients that you look at their Oswestries, you're looking at their pain scales, and looking at patients that potentially could need surgery or pain management and then don't, afterwards.
Exactly.
I think that was calling me for the procedure. Check that out.
There we go.
Hi, I'm Dr. Glenn White, practicing chiropractic here in Bloomington since 1987. Many times we have an older patient that is leery about coming to the office, or a medical doctor that is leery about sending an older patient to our office, or particularly a patient that has a herniated disc or sciatica, because they think that the only way that we're going to treat a low back condition is using with an acute patient. We do not strap in the ankles, and this table gets released, and it'll go in many different directions. It'll go into lateral bending. It'll do a little circumduction, but primarily we've used this in what we call the Flexion Distraction mode. I'll take my hand, I'll contact the patient's low back, I'll contact the segment that I want to get. Let me start out in very easy motion, very gentle. This is very controlled. I can get feedback from the patient, both verbally, in the sense that does this hurt? Am I using too much? What segment is actually the problem? But I also get feedback from my hand. I can actually feel, are there any muscle spasms? Is there a ratcheting type of motion that I feel going one direction versus the other? Now this technique is very good for things like the syndromes, for severe osteoarthritis in older patients where there's a lot of disc degeneration, the joint arthritis. Very good also for spinal stenosis, but primarily one of the things we really like to use this table for is when there's a herniated disc with sciatica. In that case, I actually can strap in the ankles. I can actually distract the patient just a little bit longer, a little bit farther down, and we get more of a true spinal decompression by using this table. This technique is much better than the spinal decompression ads you might be seeing in the newspaper. In that case, those techniques are more just like a glorified track.
So the results are really similar to mechanical traction, except you can really get a much more specific effect. Whereas mechanical traction, you got something holding you up here, and then a belt, and so it's just kind of distracting the entire spine. Whereas with this, you have a much more focused area that you're providing the distraction to. So you can apply a fair amount of pressure to the lower back, and then move the legs up and down, and so you're kind of just holding that upper segment in place while the others are distracted. Oh, this guy finally load? We can just skip that. Sorry, guy. Okay. So there are also many little gizmos and gadgets that chiropractors use. The most common is the activator. This is the one I have, and this is the one that costs about $1,000 more. So it's called the it's an activator, or there are also lots of knockoffs called the CAT, the chiropractic adjusting tool, but they all deliver this rapid. It's very low amplitude. I mean, you're talking about like a centimeter, so it doesn't work very well for really deep tissues or large bones, like lumbar spine. But I find that it works very well for cervical musculature and for small bones, hands and feet, where you're just delivering this very quick, small impulse. And so going back to those theories about the muscle spindle, how a fast stretch can cause those changes with the muscle spindle to make the muscle relax. So, you know, I'll use this for, you know, a lot of my my cervical spine patients mainly, who have the, you know, the tense scalenes, the tense, you know, rhomboids and traps. It finds that, you know, it provides a very quick relief from the muscle strain. And then drop table is another tool that we use. There will be a piece of the table. There are, you know, cervical drops, there are thoracic drops, there are pelvic drops, and lumbar. And it's just a piece of the table that has the ability to be moved up, and then a small amount of pressure on it makes it suddenly fall down. So it kind of uses the momentum of that fall to move the vertebra. It's a lot gentler. I mean, it sounds kind of jarring, but it's a lot gentler for some of the more sensitive patients than putting them in a side posture and twisting them like you saw in that other video. And looks like I'll have to just go to YouTube again.
Hello, I'm Dr. James Snapley. This is our Thompson table. This is a table that we use on people that are a little bit more difficult to move, and it makes it move the vertebra easier without using a lot of force. In this situation, we're using a drop piece that causes the body to drop down, and then when it hits the bottom, it starts the vertebra in motion. It works like such. You take contact, you thrust, the vertebra moves, you down, tissue gets up.
And
It's
then
really easy on those people.
they're basically Frankenstein. Yeah, so again, this guy has a fancier table than I do. He has the one where there's a pneumatic foot thing that you, a little pedal that you press on, and so that just lifts it up. I have just a little lever that I can pull up, but again, that's a little out of my price range at the moment. All right, so then there's also many different types of soft tissue mobilization, soft tissue techniques that chiropractors will use. And there are lots of different tools that are called either IASTM, instrument-assisted soft tissue mobilization, or there's the brand name Graston. Dr. Graston was a chiropractor who developed these stainless steel tools to be able to basically just you're scraping the area, you're trying to break up adhesions and stimulate, and you end up with kind of a vascular response where you have reddened skin, and supposedly it's increasing the blood flow to the area to help with healing. And while these stainless steel tools were developed by chiropractors in modern times, the traditional Chinese medicine has used a technique called gua sha for thousands of years, using pieces of bone or horn. And here's a little video. Hopefully this doesn't take all day to load. You know what? I'm just going to pause that.
Ah,
Oh, yeah.
how do you make them over?
You just started or?
Yeah. Wait, you didn't miss it.
Okay.
Okay, let's talk about the Graston technique here. We have several different options for tools as well as treatment techniques. So let's start with the GT1 here, the big handlebar-like device. So essentially with the Graston tools, what we want to do initially is you want to use a tool to scan the tissue to try to find your points of fibrosis, meaning areas of scar tissue.
Now, I don't do this too much on the calves because you have to be careful with the risk of throwing a clot and deep vein thrombosis. So you definitely want to screen for any risk of that before using it here. I don't have the fancy Graston tools. I actually use one of the more the gua sha tools, the piece of horn. But the good thing about the stainless steel ones is you can actually feel as you're running along. It'll resonate in your hands, so you can feel the areas of rough tissue or ropey fibers. So you can kind of isolate the area that you're going to be treating. So you can find trigger points and things like that. And then I think the other main soft tissue technique I use is called ART, and it's a set of protocols. There's a big thick book that has a protocol for basically every muscle in the body, and the technique is the same. Really, it's really knowing your anatomy. You take a point of contact on the muscle, you shorten it, and you dig in, you apply pressure to the muscle, and then you lengthen it. So this in theory is supposed to be breaking up adhesions between the different layers of tissue. But again, all these manual techniques really have similar mechanisms. Like I pointed out earlier, the stimulation of the mechanoreceptors, the gate theory, and covering up the pain signals going to the spinal cord and the brain. How about I just show you? There. Lindsay, you mind?
Oh,
Okay.
I saw that look when you said, I want to show you.
Okay.
It's fine to move most stuff for something.
All right. Do you have any soreness today or any tender areas? Yeah. Okay. No, you're too late.
If you need another one.
Okay. All right. Between the shoulder blades. So you start out palpating. Often you'll have lower trap or rhomboid pain, and the technique is similar for a lot of these muscles that attach from the spine or the ribs to the scapula. You have the patient hold her arm out, apply pressure with my thumb to the painful muscle, and then you bring it all the way across. Okay, and you can work different layers, because you can have some of the erectors, some of those muscles that run from the thoracic spine up to the cervical spine. So if different layers, and you can have them put their head down to stretch out those muscles at the same time. And so that's basically it for like I said, there are protocols for every different muscle group. Head down. How does that feel? Feel a good stretching there?
Mm-hmm.
All right. You can go back.
Oh.
That's it.
Sad.
You gotta pay for me.
He'll send you a bill.
All right. Okay, and so finishing up, chiropractic is more than just manipulation, as I said earlier. Try to get to the root of the pain. And so this involves in-depth history taking and getting to know the patient's lifestyle. And while manipulation is usually feels good in the short term, for most people with truly chronic pain, it is it's not a long-term solution by itself. So, I talk to patients about nutrition, about the medications they're taking. In fact, last week I had an auto patient who came in and he had low back, mid back, and cervical pain, and we found out that around the same time of the accident, he also started taking a statin drug that his doctor had prescribed. And as I'm sure a lot of you know, a very common side effect is muscle pain, muscle soreness with the statin drug. So he decided, I told him, talk to your PCP about, maybe switching that out. But he decided to start cutting them in half, and his cervical and upper back pain stayed about the same, but his lower back pain almost went completely away after cutting the statin in half. So, so a lot of the time it just comes down to really talking to the patient and figuring out exactly what's going on in their lives besides just the injury. So talking to them about their physical activity, their hobbies, what are they doing just day to day. Ergonomics, strength and coordination, and mindset, psychology, your emotions and mindset are very important with, especially with chronic pain syndrome. All right, so in conclusion, I'm very happy and grateful to be a part of such a caring team here. And hopefully this presentation has answered some of your questions about my profession. I look forward to working more closely with the other departments in the near future, and hopefully we can provide an even better set of outcomes for our patients. Any questions? I'm looking at you. No?
No questions for himself?
Well, I asked my initial question in between.
Yeah.
Right now, I thought that was a very outstanding presentation. Appreciate it. Thank you.
So, if you're like not a chronic pain patient, and would you still recommend going to chiropractic just for, like, I guess,